All right, let's jump right in and talk about something we all see in the clinic pretty regularly: how to manage mild asymptomatic primary hyperparathyroidism. With routine calcium screening being so common, this is a scenario that's popping up on our schedules all the time. And that really boils down to the big question, doesn't it? To treat or not to treat. It's a constant balancing act between the long-term risks of the disease itself and, of course, the risks of any intervention we might choose. Getting that balance right for each patient, well, that requires a really clear evidence-based framework. So here's how we're going to break it down. We'll start with the clinical dilemma itself, look at the main surgical recommendation and, crucially, the specific indications for it. Then we'll dive into our medical management options, what to do for monitoring our non-surgical patients, and we'll wrap up with the key principles you can take right back to your practice. Okay. First up, let's really get a handle on this dilemma we're facing today. It wasn't that long ago that primary hyperparathyroidism meant the classic bones, stones, and moans. It was a symptomatic disease. But as the Fifth International Workshop pointed out, the game has totally changed because of widespread automated calcium screening. Now, the vast majority of patients we identify are, at least on the surface, completely asymptomatic. So when we do decide it's time to act, what's the gold standard? What's the go-to recommendation from the evidence? Well, the guidelines from the Fifth International Workshop couldn't be clearer. For any patient who meets the surgical criteria, parathyroidectomy isn't just an option. It's the option. It's the only curative intervention. And look at that recommendation. Grade 1A. That's a strong recommendation based on high-quality evidence, making it the undeniable standard of care. All right, that's the big recommendation, but it immediately leads to the most practical question, right? Who exactly are these patients? Which specific individuals meet those criteria for surgery? Okay, this table right here, this is your clinical playbook. It is the absolute core of our decision-making. And remember, a patient only needs to meet any one of these criteria to be a surgical candidate. So we're talking a serum calcium, more than 1 milligram per deciliter above the upper limit of normal, any skeletal involvement, like a fracture found on VFA or a T-score of minus 2.5 or worse, any renal issues, like a creatinine clearance under 60, significant hypercalciuria or stones, or simply being younger than 50. One of those. And surgery is on the table. But what about the other side of the coin? What do we do for patients who don't meet those surgical criteria, or maybe they just decline the procedure? What are our medical options? This is a really important point to get across to our patients. Medical therapy isn't a cure. It's not going to fix the underlying problem. Instead, what we're doing is managing specific consequences of the disease. Our goals become much more targeted, either lowering that serum calcium or trying to increase their bone mineral density. And when we talk about medical therapy, we're really looking at two different playbooks. On one hand, you've got cinacalcet. Its job is to lower serum calcium, but it won't do anything for bone density. On the other hand, you've got your anti-resorptives, like bisphosphonates or denosumab. They do the opposite. They're great for increasing bone mass, but they don't reliably bring down serum calcium. So the choice really depends entirely on what your main therapeutic target is. Now, for those patients we're managing without surgery, I want to be super clear about this. This is not a set it and forget it situation. This isn't passive observation. We're talking about active monitoring with a real protocol in place. So what does that active monitoring look like? Well, here's the recommended protocol. Annually, you're going to want to check their serum calcium and their vitamin D. Every 1 to 2 years, you'll get a DEXA scan to keep an eye on the bones. And at every single visit, you need to be asking about new fractures or kidney stones. This kind of structured follow-up is what ensures we'll catch it if and when they develop a new indication for surgery. Okay, so let's pull all this together. After going through all that, what are the big take-home messages here? What are the key principles we need to remember? First and foremost, and this is the big one, surgery is the only cure, period. For any patient who is eligible, parathyroidectomy is the only truly definitive treatment we have, and it absolutely should be our primary recommendation. Second, if a patient isn't heading to the operating room, our job becomes one of active surveillance. We're not just passively watching from the sidelines. We are actively monitoring them with a clear, structured plan. specifically to watch for any progression that might tip the scales in favor of surgery. And third, when you do reach for medications, be targeted, be precise. You have to match the drug to the specific problem you're trying to solve. Is hypercalcemia the main issue? Then cinacalcet is your tool. Is bone loss the primary concern? Then we turn to our anti-resorptive agents. And this all kind of leaves us with a really interesting question for the future, doesn't it? Right now, the guidelines for asymptomatic PHPT are pretty clear. But as we learn more about what we might call subclinical disease, things like subtle neurocognitive changes or potential cardiovascular risks, you have to wonder, will these indications for treatment expand? It's really the key question that's going to shape how we manage this very common condition in the years to come. It's definitely something to keep an eye on. Thanks so much for tuning in.